Interestingly enough, one of the reasons we put this together is people will say, well, why are you doing this? Don't you want to have all the DEUs in the area? Why are you trying to teach everyone how to do this model? So I think it's important to make this comment now that one of the reasons we put together this DEU model for the local area is because we were asked to do this by one of our clinical partners. And when we were asked to do this, it was to help really educate everybody in the local community and hopefully get to those health impact, those outcome measures we need to look at. And one piece of that puzzle is that people were trying to query their nurses. Were you in a DEU model when you were here as a nurse? And they found out everybody was saying yes, but they weren't. So students didn't even necessarily know that they were in a DEU model because the way that it's done, and everybody is not doing it the same way. So there's not that clear delineation between, yes, this is a DEU unit, or I'm the instructor that goes on the floor and I'm going to ask nurses to help me with the students. So I think that that's really important for us to acknowledge as we're trying to build the model. And really the idea here is, we have lots of nursing schools here and we compete for students, right? But we also impact the health of the community. And what comes first? And we're all nurses, right? Yes, we want our students, we want them to do well. The hospitals, we compete for nurses in employment. We need to have a standard, and wouldn't it be great to have a standard of care or keep these connections to say what we're doing is improving outcomes, and we'll talk about the development. So Karen and I will be talking about really that piece that people mentioned when they came in. How do you keep this going and how do you sustain it from a clinical partner perspective and the educational perspective, not from just the nurses that are on the units teaching in DEUs, but what does that mean to your school? So that's really important to have leadership representation, because it can't just be the clinical instructors who make this happen. And we'll talk about that throughout the presentation. But I did want to share that, because if you can't identify if you were really in a DEU and you're not sure, because if you're asking the nurses to self-report, they might not be able to correctly articulate that to you. You would know it if they were on a DEU unit, and that unit is taught only by the DEU models. So that's something for us to think about too. Linda has talked about that first step, and really when we talk about looking at our shared values and what we can do with our clinical partners. So this is something that I really just want to talk about from the School of Nursing. So your unit, how do you help do that? Not just this idea of it, but what do we really do? And it's really a win for both to start this very early on. We talk about the establishment of partnerships and recruiting of clinical instructors. So if you don't have a DEU already, Karen's going to talk about making those decisions from the clinical provider standpoint. But before you start to do this as faculty or leadership at your institution, you have to really start thinking about the people that you have really good relationships with already. Because if you don't have that and you come in and talk about this model, it's going to be hard for that institution to understand the benefits. So you start out with the shared values and goals, talking with people that you already know, and then you can build on those. And we'll talk about how we've maintained that relationship and how we've built upon it. And the other piece that if you're, and I'm talking from the academia perspective, so if you're going to be asking for clinical instructors, which are your DEU preceptor nurses, and what they're called at different institutions may change, because sometimes you'll have a union environment that if you call me a clinical instructor or you call me something else, that impacts my pay, that impacts a lot of other things. So it's really important to have these discussions before trying to implement something and looking at what that needs. So we try to go out when we're making our partnerships or growing our partnerships, but you have to start with an awareness of what that may be. So who you're having conversations with first about this and who is having those conversations becomes really important. So we want to sell, as an academic, the importance to the institution, but we also have to have this level of awareness of what that might mean for the institution before we get there. One way to always start this is we're all nurses, we're going to healthcare organizations, being nurses, is trying to look at some of those shared values. Linda talked about the idea that we all want to do the best for our patients, we all want to have the best nurses, we want to have them know what they want to do, but it's really easy to kind of look at a mission or values within an institution when you're having those meetings and start with talking about what those shared values are. Because if you're an academic and you go to an institution that doesn't have a DEU, one of the things that can happen is it's going to, you know, like anybody, if somebody comes to me, what's in it for us? This is the reality, right? So what is in it for both partners? And those conversations need to happen. And as much of your nursing administration in academia, so your deans, your assistant deans, your program coordinators, the more people you can have involved with developing those partnerships, the likelihood is better for your success, because you have this, not only one person, but multiple people who in every interaction can talk about this model and talk about how important it is. So I just have up here our eye care values, and every school of nursing has some mission and values. These may look very familiar. You'll see them. Actually, I noticed when I was at the VA the other day that they have eye care also, the exact same values. However, they mean some different things. So how many people have eye care? Okay, so there's quite a few different people out there with it. So these are our values, and then I was going to have Karen just talk about, if we talk about integrity, collaboration, accountability, respect, and excellence, Karen's going to share how they match with some of our ECMC's values.
At ECMC, excellence is a standard that will never be lowered. There's an expectation of excellence in all areas. So that's something that's foundational at our institutional level, but also right on the unit level and right in the individual nurse. It's something that we try to foster within them. Diversity. We recognize the importance and value of diversity and the enrichment that diversity can bring to ECMC. And we try to do that right at the unit level and right when the nurses are oriented and educated in most every avenue. We feel that diversity is very important. The concept of being inclusive, the concept of being flexible, so that you're able to meet diversity and inclusion needs to resonate within our institution. We also feel that dignity, that each individual, no matter his or her limitations, background, or situation, has intrinsic dignity and unique capabilities. Those are our foundational kind of our stepping stones in our institution, but also within our nursing department, on which we base many of our educational components, and what we also encourage our nurses to seek, collaborate, to inform us when they think that this is not occurring, so that we can do a 360 really quick turnaround to look to make sure it's occurring.
And then these additional ones, sorry. Sorry.
We also naturally believe in fairness and integrity. Equity and fairness are guidelines for all of our decision making, to have a formalized shared governance structure in which the frontline team is able to give input for everyday decisions. We really believe in that, and we encourage at the unit level that this is completed and all the way through. Collaboration with other organizations is beneficial within the context of our mission and vision. Someone passed me a little note, thank you, Nicole, that we have over 2,000 plus students, nursing students, that come to our institution. And I think it's really important for us to collaborate and really, I don't know, to be the strong stakeholder that we would want everybody to be in setting up nursing the way it's supposed to be for all of the student nurses, so that someday when they look back and they say, how did I start? Who helped me? What was the foundation? That they would be able to look at our institution and they would be able to say, this is where I got my beginning. This is what I could attribute my success to.
So if you look back at that idea of our eye care, we have integrity that's shared, we have accountability that's shared, we have interprofessional collaboration that's shared, excellence, so there's no question that I'm sure everybody could do this in this room. And if you can't, well, go back and look at your mission and vision. But if you can walk in and talk at that level when you're starting about how we're a good match and have those types of conversations, or that continuity when something isn't going on, where can we go back and what can we talk to make this a little bit different? The other thing is, and again, this holds true if you're just trying to approach a hospital system or if a hospital system is approaching you about this, being really well versed at what are the benefits. So Linda started out talking about some of the benefits. So we share this with you that we put together, and everything that we are talking about today as we get to implementing this, these are all pieces that go into our orientation that we provide. And later in the day, we'll go through actually what our orientation is and how we hold those. But this is really important that people have a good understanding of what this looks like. So what are those benefits? I don't want to go too much into this because I think Linda has already discussed this, but again, go in with some tools, go in with some research to have the conversations about building these DEUs and why they're important. Because whoever you're meeting with, so if I'll talk about one of our partnerships with ECMC. Mine was an email to Karen, can we meet and talk about something? So whoever it is you're meeting with, Karen has a boss she has to report to, right? So if I'm going to go and talk to Karen, Karen's going to have to, even if she thinks this is great, which I know she does, she has someone else she has to turn around and convince that we should be doing this here. So the more tools that we can give our clinical partners, if we're an academic, to make this happen, the more likely you're going to get buy-in at another level. Because as nurses, we can think about the DEU model and say that sounds really great, but we need somebody else to provide the evidence. And that's, I think, why we're seeing our clinical partners trying to identify, did the DEU work? Were these DEU nurses? And one way to get there is to better articulate and be sure, if you say it's a DEU, it really is a DEU. So, and if we're kind of calling something a DEU and the students don't know and the nurses on the unit don't know, then how are we ever going to say this impacts outcomes or patient care? So that's really becomes important. We just wanted to share who we have our current DEUs with. As Linda mentioned, we have quite a few of them, and we are in every major healthcare system. And I wanted to share with everybody some different things that go on with UB and how we have these meetings. So what do we do to build these partnerships? And it's really important that if you're in a DEU unit currently, you see them falling apart. Remember we talked about that planning? You have to replan, you have to change how it's going on, but making sure you're talking to the right people. So if you're a clinical instructor on a DEU unit and it's falling apart, sometimes you feel a clinical faculty member, I want to say, not a DEU preceptor, but you feel like, what can I do? The nurses don't want me here. So it's so important, hopefully that's not happening, but we know that it does happen, right? Like they see this as a burden, what can happen? We really need to then go back to the unit managers, the administrative people, both in academia and in your institutions that you're in. So you have to build those relationships and make sure there's some kind of ongoing communication. So if you're the clinical coordinator for a course, or if you're a program director, assistant dean, whatever you may be, those lines of communication have to be there at every level. So who is your equal in that institution? Because if you're the clinical faculty person, you might not be the right person to be talking directly to the chief nursing officer. You might be, but it just depends, right? So making sure, because that's showing two things, the importance to the clinical partner and the importance to your organization, so that you don't feel as the clinical faculty person at the site that you're the only person making this happen. So making sure there's some kind of routine discussion and feedback loop. And that also happens with our clinical coordinators at the hospital. So since I'm talking about ECMC, like Nicole Durenda is here. So we'll meet with Nicole. I've met with Nicole independently. You know, there's got to be a buy-in from everybody and not just that one person on that one unit to keep growing and developing these partnerships. And I'll come back to ECMC when I talk about our expansion to into primary care. Catholic Health, I mentioned that, you know, we are involved over there. One of the things that has come from our relationships, and that was on Linda's slide, relationship building, is having that presence. So Catholic Health actually invited us through our partnerships to come in and do a DEU presentation for all of the unit managers. That was like, we were so happy to be at that table. So how do you build that relationship so that you are invited to come and talk to every unit manager? Not just that they heard about this from somebody else, but you have a seat and you can really sit there and provide what we're going to show you later as our orientation to the managers who are making those decisions. So if you have somebody at a higher level who's the chief nursing officer saying, like, I think this is a good idea, we know that has power, right? But the nurse manager on that unit has to have that buy-in or things are not going to move forward. So you can see our success there and the importance of our being able to keep those connections and going in to talk with people. Kaleida Health is our work in progress in terms of expanding our DUs. This is probably one of the places that we have the fewest, but we still have a presence there. And hopefully we're going to mimic what we've done at Catholic Health with the Kaleida Health, but you know, recognizing what we can do as an academic partner for your clinical organization. We have additional DEUs at Roswell Park, and one of the nice pieces about that too is we do have an OR DEU there. So one of the questions becomes, can we have them in specialty units? And we have other specialty units too. We have a cardiovascular ICU and a couple different things in different hospitals. How do you make that a DEU when you have other students there becomes important, because that clinical faculty presence has to be on the units also. And Michelle's going to talk to you about what DEU doesn't stand for later, and hopefully you'll get a laugh out of that. Also at the hospice DEU, that was really something that was very new when Joanne Chimura started it, but how do we maintain that? And that is really by having that presence and ongoing communication. One of the struggles in academia is when you have turnover for your clinical faculty. So we build these great relationships, but as everyone in this room knows, it's very hard to find clinical faculty. And then to keep the clinical faculty, right? So, you know, working in practice settings pays better. It's hard to do clinical and have another full-time job. And a lot of us use part-time or adjunct all of the time. So it's really hard to maintain that. How can we make sure that does not impact our clinical partner? And that's another perfect point in time to bring your clinical coordinators, your program coordinators, or someone at a higher level in to talk before it happens. So if somebody new is coming in, not the, oh, guess what, this is the new DEU faculty person this semester, but let's talk about what that means. Let's do a handoff. So Linda's at hospice. Linda and I had a great meeting with their person, Hilda, who is the head of their staff education, and or not the head of their, Kelly Clem, who is a vice president. I'm sorry, I'm so bad with people's titles, but she's a wonderful person at hospice and she does all their education. We also met with the person who coordinates the clinical experiences. We talk about what was done in the past and what needs to be done in the future. That's ideal, right? Because I'm still here and Linda's still here. It doesn't always work out that way. So making sure that, that it's not just the clinical instructor at the facility who knows what goes on at that facility. This is really a team approach. So we're fortunate enough to have a clinical coordinator. How many people at academia have a clinical coordinator at their institution? So pretty much everybody is moving that way, but making sure that your clinical coordinator is really well versed in this is very important also. So the other thing I want to mention is how do we get to, so Linda talked about having a plan. So we partnered with ECMC and the VA to start the first DEUs in primary care. So people may have students rotating into primary care as a shadowing experience, And we know that their future of nursing is going to still be some at the bedside and some in acute care, but we need to educate nurses for practice in primary care settings. So how this came to be was through meetings between Karen and I, then meetings between Karen and I and the unit managers, then meetings between the unit managers, Michelle, Donna, and I, and then faculty teaching in it, and then DEU orientations for the new nurses who are going to be our CIs like Michelle Mooney, who happens to be here today. So when we talk about this, wow, planning, very, very important. We started talking about this, I think, at the end of last fall, maybe around November, and we implemented it in September. Same thing happened with our partnership at the VA. We also have to be ready for things that don't work out. So we had really hoped to have eight students in primary care, but sometimes it doesn't work out. So you have to realize and have a backup plan, because when it doesn't work out, you have your students in academia to be accountable for, and then Karen will talk about what happens there with those students. And the other really great partnership that we have that we wanted to talk about was the Visiting Nursing Association, and they have a new nurse residency program that I know the local schools have participated in, and we are fortunate enough to have 5 of our graduates from last year that were hired into the nurse residency program and are working there direct from college. So when you talk about new grads working in different arenas, these are things we're going to see in the future. So when you're talking about your DEU development, you really need to start to think outside of the acute care settings. And what does that mean in terms of manpower and establishing those relationships? The DEU in home care was a little bit easier of a transition for us because we had the hospice home care one. And again, we have great relationships with Robin Brown, the person who was leading that initiative. So it becomes really important in terms of planning, timing, and really looking at, if it's going to take us 8 months to get this done, we might not be able to do this in January, because we're all thinking about clinical for January already, right? So either as a practice partner, the schools are saying, can we have that unit again? Or we already had it for a year, you better, those types of things, and us for scheduling students and faculty. So when you think about timing of things, if you have new DUs coming up, please make sure that you're having these meetings that we're talking about. If you look in your folders to the left, there's the very first thing there are some primary care objectives for students. So when we talk about the meetings, because they're a new unit, people get very scared. People were a little frightened, like, what are the students going to do in primary care? So we had to make sure that when we went to those meetings with the unit managers, we didn't want them to have to figure it out. The academics have to figure out what we think we want to happen. And then we partner and collaborate with, does this make sense? And how can you help us make that happen? So that right from the beginning, there's that ongoing dialogue and communication. I'm going to hand it off to Karen to talk.
I guess in the absence of research, Dr. Stieg, that'll tell you that the DEU is beyond statistically significant, I would like to give my own personal testimony in terms of why I believe DEU is one of those key elements that changed the nursing department at ECMC. In 2008, I was a new assistant director at ECMC for the medical surgical units that had high turnover, dissatisfied nurses. We were still functioning under a model of mandation. And I can now fast forward to 2019. My turnover is in the lower single digits. My agency usage is probably 99.9%. We don't use agency. And I don't worry about nursing shortages because I have so many people on waiting lists to come to ECMC and my med-surg units that I literally am almost semi-stalked in the community as to people that want to work at ECMC. In terms of where are my DEU nurses? I look around and they're right at ECMC. I have my original nurse managers from 2008 are still present. I myself am a living testimony that I'm still present. Many of the DEU nurses that I have at ECMC have gone on to educational positions, leadership positions, high clinical leader positions. DEU is almost an entry for the very best that we want nursing to be. And I say assign a DNP to ECMC and you will get your statistical significance so that someday if you chose to retire, you could. But I do think that it is important to state, I think it is one of the pivotal models that can change a nursing department and to move your quality indicators. I can state that our quality indicators in 2008 when I came aboard were, according to Leapfrog, which is a national nonprofit organization that tracks quality, were not the best. And we have hit, being a safety net hospital, we have hit Leapfrog A and Leapfrog B. So, and that's really hard in a safety net, while other people are dealing with post-operative knees and hips and very small incisions. We're dealing with axes in the back and burn patients with CLOBSIs, and I can't even tell you all the things that a safety net hospital deals with. So to hit that A and to stay at a B is actually very different looking for an institution like ours, yet we really don't struggle with that anymore. Again, I can truly attest that I think it's part of the DEU model. Why do I think DEU is important? I think that there has to be buy-in from everybody. Everybody has to change their mantra in terms of how are we going to welcome nurses into our institution? How are we going to change how we interact with the students and ourselves? We need to change our entire culture so that the DEU eventually not only succeeds, but excels within our institution. We have DEU affiliation with the following schools and nursing programs: UB, obviously, DeUval, Niagara, and GCC. So, and we value all of them, and we meet with all of them, and we encourage the growth of DEU. We're happy that primary care is coming aboard. We have Kelly Wilson here. We're going to re-energize and reformalize our DEU in behavioral health so that we can get the utmost that we want to see, and that the nurses that come to us are actually going to get the experience that they deserve, that they are going to need as their foundation for education into nursing practice. And we actually, and I shouldn't even put this out there, but we actually are thinking about, for the first time ever, having a DEU in our ICUs, which we've never had before. So what do I do? What, as a leader, do we need to do? I think one of the first things that I realized is that if I made it important, if I treated it like something different, if I acted in a different manner towards it, everybody would respond to that. So one of the first things I did was I negotiated a pay raise for my DEU nurses. And I know that's controversial, But I can tell you we have very little money. We're a safety net hospital, but I felt that was very important because I really wanted the DEU nurses to be the top of the line to give back to our student nurses. And if they needed to do research, if they needed to step back and really look at the fundamentals of teaching, I wanted them to do that. And I wanted to support them in any venue that I could support them to do that. Did all of a sudden I come out of the woodwork with many people that wanted to be DEU nurses? Yes. But truly, I selected the people that I wanted to actually, I don't know, wrap around the brand new nurse and to educate her in a way that we would all want to be educated, that those nursing faculty that we remember in our hearts to today, I wanted my DEU nurses to be those people. And I think that that's something that we should all demand of as teaching, as faculty, and as service. We need to make it the way it's supposed to be. Not put together on a shoestring and tell the nurse, go ahead and look this stuff when you're at home and do it on the weekend or on the way into work. Do it the right way. Do it how it's meant to be, and you will get the results that you want to see. It's just how you would set it up. So I think, what do we pay extra an hour? Nicole, you know this. $5 extra an hour I give the nurses. Yep. And we are not, just so you know, we are not at all the highest paid institution in the area. We're one of the lowest paid institutions in the area. But I put my money where I think it's important. So healthcare delivery model, I think that you need to really look at the structure of your units. Who are your formal leaders? Who are your informal leaders? I say get right in there and really take a look at every single person that's going to interact with your student nurse. And I'm talking your unit secretaries, your pharmacy techs, I mean everybody, because everybody has a role to play with that new nurse. And everybody has to be engaged in how they're going to interact with the nurses. Get the docs involved, because you really want the nurses to, once they're comfortable and once they're taking care of the patients, you're going to want to have them you're going to want to have that interdisciplinary process, and you want them to be involved. But the doctor doesn't know DEU. He doesn't know that at all. Believe me, they don't. So you're going to have to help educate them. You might have to help educate your care management, your social work. It's important that you really help establish what you want to see for that nurse. Because if people brush that nurse off, male or female, and they brush them off or don't treat them respectfully, is that how you would want your nurse treated in your institution? So I say get the key stakeholders all involved, all engaged right in the meeting, and set the standard that under no circumstance is that student to be brushed off, to be disengaged. We want to be as welcoming, we want to be transparent. Things are not perfect, but we want to make sure that they have the type of experience that they deserve to start their nursing practice. I think you have to look at your unit. Many units have specialty considerations that the student nurse may be unfamiliar with. You may have a patient population, a patient demographic that they're going to need education on, or you're going to have to let the faculty know. In behavioral health, there are so many different nuances with families, with CPS, with law enforcement. In a safety net hospital, this is all routine. But to many people, they're like, oh my goodness. So you're going to have to engage everybody and bring them in, that this is our normal practice, that our nurses here have to advocate at a very different level, and we have to advocate sometimes even over the government institutions to make sure our patients receive the resources and equity that they're deserved. Is that not right, Kelly? Yes, we do. So, and we also, we deal at ECMC with being safety net, many of the gangs. So the student nurses have to know all of this because it's a unique type of institution. The type of clinical experience is going to be different there than anywhere else. And we want to set the stage for acceptance, for success, but also to recognize the special consideration. So keep that in mind, Michelle, because there's a lot that happens in our clinics that there definitely is that they're going to need to know about, and the stakeholders will. Staff consistency. I think that's very, very important. One of the things that we really have a mantra is that if you're going to be a DEU, this is what your schedule will look like ahead of time. Now, naturally, illness and death you can't foresee, but I don't want to start a DEU with someone and then find out they booked their lifelong trip to Europe for 2 weeks. They have to be committed as we're committed, as the student is committed. So I'd have those discussions ahead of time. I'd say, this is what it's going to look like. Are you able to complete that at least 80% of the time? Because then you know there's going to be consistency with your student. There's going to be relationship. There's going to be trust building. It's all of those intangibles that are the most important for the student to have. You need unit champions. You need those people that say, DEU is the way to go. DEU is what I want to see. My managers are huge champions of DEU because they know that if they wrap around and do all of the things that we've now discussed, that in the end, if they have job openings, if they have positions to be considered, many times it's the DEU nurse that wants to work at ECMC. We actually get calls up to 3 years later by the DEU nurses, and they will call my office and say, I'm on year 2 and I'm waiting for an opening. I want to come back. I'm working here, I'm working there. Are you going to have an opening soon? So I think it's really important, because I think that if you can leave a person that they want to come back, that even though they have to go somewhere else, and I always tell people that do go somewhere else, don't consider it a closed door. We're always an open door in terms of resources, in terms of education, consultation. Many hospitals struggle with the behavioral health patients on med-surg. I'm always like, please consider us as a resource. We're happy to consult, help care plan, treatment plan, whatever you would need for us to help you. And then also look at your experience level of your RNs. Obviously, your DEU should not be people that have practice issues, performance issues, engagement issues, even filter issues, participate in horizontal violence. I could go on, and all the people we wouldn't want to have as your DEU champions. You want people that are engaged with students. You want people that have the heart of nursing. You want to have people that really want to provide the wraparound for the nurses, but have that inquisitive mind that students need to hear about, and that they would feel comfortable asking those questions. And everyone knows that we're all learners, no matter where we are, no matter what we do. And you would want people to feel comfortable asking what they feel is a dumb question, but it's probably a question 1,000,000 people have asked. And you want them to feel it and not like, oh, people are going to laugh at the person, or bring them to the desk and say, hey, guess what they just asked, right? You don't want that to happen. You want people to say, oh, 1,000,000 people had that question. I did too. Nope, we don't use that tube for that, right? So, and I just think that that's something that will help will really help make your experience very worthwhile. One of the other items that I did was that I always went to post-conference at the end, because I wanted to ask the students what I could do better, what we could do better. If I gave them a magic wand, what would they change? And who were the people that made the difference to them? Because I wanted to go back and recognize them. I wanted them to go back and realize that they made a difference. Joint appointments. I think it is an answer to the faculty shortage, but I also think it's a way of furthering your growth opportunity for your nurses that want to have that nurse education growth. We did have a joint appointment, both UB and ECMC, and I'm not going to say that my joint appointment actually works for UB now, but that's what happened. But I'm sure that that was just who knows, just a phenomena that happened. But I think it was important because there's limited positions for nursing education. How many work in institutions where their nursing educator receives the job and keeps it all the way till they retire? Who has ever worked in institutions like that? Well, I know we do, so no one else does. Do they change over a lot at your institutions, nursing education?
Yes.
Do they?
Some. It
Some
depends.
do?
Some. It depends.
Not really? Well, at our institution, they never change over. So basically, anyone else who wants to be in nursing education would have to wait 20 to 40 years to get a position. So this was a wonderful answer on really promoting somebody so that they were able to work at ECMC and work at UB. We had our legal teams work on this, and our HR. I really had to sell this because we're in a unique position because of retirements and everything else, but I worked it all out, and I think it was very fruitful when we did have it. It continually employs nurses with advanced degrees, and they're able to move up the ladder. New York State does require the MS in nursing. I do have to say that was a sticking point. I had wonderful candidates, but their master's was not in nursing. So therefore, UB could not employ them on their end. I could employ them on my end, but they couldn't employ them on their end. So I'm sure there was some disappointment, but you know, the law is what the law is. So we really set aside time to do a clear delineation of role and responsibility. We also set time aside so that we met frequently during the period so that we were able, is the person at our hospital, is the person at UB, so we were able to really define what we needed to. And then we also discussed liability issues, and we definitely had a legal contract for all of that, but really everything worked out very well. And I think it was a win-win for the individual involved. And it really answers what to do with all the very best and brightest that you are bringing up the ladder. Where do they go? Especially in an institution like ours where there's very little turnover in nursing education.
So I think we already pretty much went over this, so I don't want to go on to that, get into this too much. You've already talked about the impacts on your facility too. That's the beauty of PowerPoint, right? We love what we do. We're so passionate about it. We get to it before the slides. So, and actually we'll talk a little bit more towards the end for time's sake about collaboration and promoting evidence-based practice. But we do want to share with you some of the projects that we have done, and we'll talk about those at the end of Donna's piece and when we have our panel up here, because these are great avenues for faculty, for opportunities for scholarship, as well as impacting clinical practice.